We're here with Astra Biomedical Group, which is a nonprofit organization. We're currently focusing on promoting awareness of biomedical research, right? And one of the most pressing issues for I feel like for teenagers today, right, is the topic of mental health. All right. Just in terms of numbers, the depression is the #2 cause of disability in the US, right? Aside from diabetes and heart disease, right? So it's a really pressing issue, right? And there's a lot of misconceptions that occurred regarding it, right? Some people often consider it to be, a passing phase of sadness, right? And in general, it tends to be, I think, trivialized, despite the fact that it often can be a very, life-threatening and debilitating disease. So, who we have here today, we have a special guest speaker, which is Dr. Stephen Chow, right? He is a neurologist, and he currently is working at the Palo Alto Veterans Association and is a Stanford Associated Professor of Neurology and has been for over 10 years. MD, PhD, he got it at Chicago Medical School after and completed a neurology residency at Stanford, as well as behavioral neurology fellowship at UCSF, right? In general, his specialty is in neurological disorders such as dementia, traumatic brain injuries, headaches, right? And often there is a correlation between, brain injuries and, mental health disorders. So is there anything else you'd like to add on regarding your experience here?
Thank you for the introduction. Yeah, I'm a neurologist. So in the past, actually neurologists and the psychiatrists are very similar. We share the same board until we separate later. So a big part of differentiation is most people think neurologists are the physical part of the brain, and the psychiatrist does the kind of the psychiatric part of the brain. And the behavior neurology actually is a combination of these two. We study which part of the brain causing what kind of behavior. That's what the behavior neurology is. So the reason I'm kind of a little bit into depression is because I see a lot of patients nowadays with PTSD, depression, just like Annie was saying about the traumatic brain injury, dementia. They all have very strong association with these two diseases. So I'm gonna talk so you guys can ask questions, mostly youngsters, and I will try my best to answer them.
Oh, would you like me to screen share your presentation? Do you want to go through it really quickly?
About that. You guys can ask questions.
Sure.
Actually, that was an old talk. I already changed quite a bit of it, maybe every single slide.
All right. So basically, in terms of depression, right, it is a part of a category of, mood anxiety disorders, and depression is both a disorder, which is like major depressive disorder or MDD, right? And it is also a component of other anxiety or mood disorders such as bipolar disorder or seasonal affective disorder, as well as, other depressive disorders that are caused by, substance use or mood regulation issues. So off of that, oh, sorry.
你要我下来吗？
Oh, did anyone have a question?
No, Annie, you're fine.
Awesome. So let's just start off with the questions. What is depression, right? Is it just people feeling bad? And can people who have depression become happy if their friends can cheer them up?
All right, so that's if anything, more philosophical than like pathological, because number one, depression is very unique disease. So it's not like a typical disease that we know what's the true pathology behind it. So good example is like COVID. So COVID, we know there's a virus causing the disease and causing a symptom. So when we have the disease, we can test a PCR test and we confirm that people has the disease. But depression is not a disease that's defined by a pathological change. So really, it was defined by a change in people's mood. And the reason we call it a disease because it causes a lot of functional disability. And maybe even like Dudu said, someone might lose their life over it. So when they affecting our normal function, and maybe we have a risk of dying from it, we say that's a disease. So when you say, so what is depression? So most people define depression as a mood disorder. So when people don't feel well, I would say to the point that they're not able to function, then that's depression. But what's the cutoff line? Because some people just say, oh, I feel tired today, I don't want to do my homework. Is that depression? May or may not be, right? Because there's a whole spectrum of mood issue. So the people has mood, like, well, a lot of animal has mood because we need it. We need to enjoy the life. We need to feel sad. So it's a huge complement to our normal function. So I would say when people have this mood become mild adaptive in the way it impairs our normal function, then it becomes a disease state. And to define this and to really pinpoint that, it's not an easy saying that, oh, this person look depressed and then he must have depression. That's why we do need a professional help. That's why a lot of the people who has mood issues need to see a psychiatrist or some health professional to get diagnosis. So it's not a easy question.
From my understanding, in general, clinical depression usually falls into a couple of someone's raised a hand. Did you have a question?
No, I wanted to say that some mild mood changes cyclical too. So sometimes we feel happy and sometimes we feel sad, and that's natural. And Dr. Stevens says, Dr. Chow said that it's only when you affect your daily life that is probably diagnosed depression, but the mood changes is cyclical as well. So sometimes especially for females, that would be monthly hormonal changes, and that can affect the mood changes every month.
Yes. To clarify on that, actually, so clinical depression or major depressive disorder in the DSM-5, which is the diagnostic manual used to diagnose mental disorders, says that depression is a persistent feeling of, low self-esteem, low mood, low energy, apathy generally, right, for 3 or more months, right? Now, a quick, I guess, additional note onto that is that, again, depression takes many different forms, right? I think in general, just to clarify, whenever we talk about depression as a general term here, we're referring to like either clinical depression or major depressive disorder, right? There are other like depression related disorders such as bipolar or, I guess, emotional regulation disorders, right, that are associated with depression, right, but probably will not be, what we are talking about here. So another question here is, what causes depression?
Let's go back a little bit because I did answer the second part of the question. And also, you are precisely right that depression, there are criteria for that. And some key part of it, I think you are asking about like when you are depressed or when a person depressed, can the friend make them happy? So in medical term, there's a term called anhedonia. Anhedonia means inability to experience pleasure, which means that you're not able to enjoy yourself. So in people with depression, this is one of the symptoms, but it's not all the time. Some people can still occasionally experiencing pleasure, but it's a spectrum. If a person truly cannot be happy, and that is a very strong suggestion for depression. And also, when we look at people, as a physician, we do physical exams. So we look at a patient or like a person. The patient or the person should have a full range of emotion. They should be happy, it should be sad. So when people has we call a flat affect, the people who come in doesn't look happy, they just look sad. And then that's another indication. But as I said earlier, there are many things in life can trigger people to have a depressive mood. Like if your pet die or something happened, you score really badly on the test, that could make people feel sad. But there's a time frame for it. So most time in medical term, like Annie was saying that 3 months is a cutoff. So even a major family loss, things like that, people should not feel sad more than 3 months that interfere with their function. A lot of people, when they have one thing happen to their life, they could take a few days off, but that's normal mood swing. It's not depressive disorder yet, unless they don't get better. So that's everything on this one is a spectrum. So a lot of time when we try to diagnose people with, I think that come to the second question about how to diagnose people with depression. They, number one really is talking to the person to get the story, so what bothers them. And then we sometimes go through questionnaires, typically like 30, 60 questions. And then this is because this is they have the normal distribution. So we try to put this one into a bell-shaped curve to which part of the bell-shaped curve you are at. If you're 2 standard deviation away from the mean, then we think that's abnormal. Supposedly, most people are going to have a little bit sadness in their questionnaire. They're going to ask you, like, compared to other people, do you feel you're always better or not? And sometimes you don't. And do you feel hopeless? And do you feel sad? So even with normal people, out of these 30 questions or 60 questions, we're going to answer a few of them positive. Like very few people, if there's a 0 question is negative, then we worry about the person being too happy, which is the other spectrum of the disease, which Annie talk about the bipolar. When they're manic, they think everything's perfect, there's nothing wrong with them. They're on top of the world. So there's a norm right there. So when we try to diagnose any disease, we try to put the norm distribution there. Then we see, oh, where is that? But again, answering question just part of this, because not everybody answer the question as it's supposed to be. Some people might not want to admit their own problem, but some people might not even realize their own problem. So this is a part of the diagnosis test. A lot of time we really have to ask about their functional things. So number one, their clinical symptoms to see whether they feel sad or not, like how long they've been feeling sad. Number two is their functional status, was this affecting their functionality at home or not. Number three, then we ask about their other things, because depression not just purely a thought. It affects your function, then it affects your sleep, your appetite, your weight, all kind of physiological functions could be affected, like concentration, memories. If all this being part of that, and then number four, we might do some kind of almost semi-quantitative testing, like a questionnaires or some kind of a neuropsych testings, and to see whether this is truly a depressive disorder or not. And I think since the disease is so complicated, a lot of time it can cause by physiological changes. Like I think one person was mentioning about
we've got a question from a Shan Zhao here.
Yeah. So
maybe,
hi. Okay, yeah,
sorry, I just want to know, as because most of people are not experts on this, how do you think this alarming signal that the person might be in depression?
So what's the thing that triggers almost like the bottom line, right? So I would say it's very difficult because some people can hide it pretty well. That's why in in the hospital I'm seeing veterans. There are about 2,000 veterans commit suicide every year, which means about several per day. And a lot of time they actually look fine. They're not telling anybody their clinical symptoms. They behave just okay. But when they go home, they feel sad, they feel lonely, then they commit a suicide. I personally have seen several patients like this in their 20s and 30s. They might have seen me even like a week or two prior. They actually look okay. They might look a little bit of like uneasy, certain thing. But even you ask them to have suicidal thought, they might even say no. And then when they go home, they really kill themselves. So this is extremely difficult to see what is the simple cutoff. Like if this happened, then we have to treat him. If it doesn't happen. I would think the real bottom line is that if the patient or the person are meeting, they're gonna have a suicidal thought or try to hurt themselves. I think that is the bottom line, that you have to get them help right away. Other than that, then it's really a judgment call, whether it's functional. If you found the people really functionally impairing, or maybe Annie, you have something to add?
Yeah, a quick add-on here is I just want to clarify that for most people who struggle with depression, it usually doesn't lead to suicidal thoughts, right? It tends to just be a chronic disease, you know. And I do agree that seeking help is very important if you feel as though your loved ones, right? Even if you think that it's, you know, like maybe a passing phase, right? At least reach out and try to talk to them about it, because knowing that there's someone out there who's looking out for you is, you know, really important in the prevention of it. And so we do have a couple of, oh yes, Joy has a follow-up question for you.
Yeah, sorry. I think you and Annie both gave some surprising statistics regarding depression and suicide. And I was just wondering, why do you think depression is so common?
There are multiple folds of that. There are many people did study on this. In the old days, I think at least half of the people here, they come from different country. When they were young, they didn't even know what depression was. So part of it is they didn't know what depression was. So they, even though they feel sad, they're not able to function, then they're never put on a label. So by better diagnosis, understanding the disease, we tend to see more of this. Number two, like you almost never seen very few, I don't know if they have pets or not, cats and dogs, they almost never commit suicide. Because in their mind, they're always something they need to do, because they need to look for food, they need to look for shelter. There is thing they need to survive. So depression is slightly more common in, I mean, at least based on statistics, more developed country. So when people have all their basic need, somehow our minds start thinking more about what else we need. When you're the one who every day looking for things just to survive, there are almost no leftover resources for the brain to process. How do I feel today? I basically just feel tired. I need to eat, I need to sleep, I need to get a shelter. So that might be part of the reason. We really don't know why, especially nowadays. The depression is bad, but the ultimate final outcome of suicide is really the worst outcome we can ever possibly think. And that's really is on the rise, especially among Asian teenagers. It's really high prevalence, as Annie said. So like you said, maybe is we know it more, or maybe it's our environmental changes, or maybe it's because we're doing better. So it's a genetic condition. So maybe people with depression, when they're treated better, their gene get passed on. Maybe in the old days when they're sad, they just never get married, so never have kids. So after generations of good life, when people have kids, the gene become more prevalent. So all these possibilities we just don't know yet.
Right. So another question is, what are some of the long-term physical health effects of, you know, depression? Like, you mentioned how it has an impact on your day-to-day life, and one of the like diagnosing criteria is that it impacts your life. But over time, like in, you know, both patients you see and just, you know, like clinically, right? what do you think like are some of the impacts on, their well-being and, their health?
So I think there are several layers of this question. So number one, the most obvious things, like when people are depressed, they don't eat well, they don't sleep well. So their day-to-day life is kind of messed up. So that will take a toll on their nutritional status, on their growth, especially when you're teenagers, time of growing, they don't sleep well, they don't secrete enough growth hormone, they might be underweight. Some people also have a different kind of eating habit. Most people lose weight, but some people do eat more, they're gaining weight. And so in terms of the other part of the body, I know the brain the most. So with brain scan, we know that people who with depression has a smaller hippocampus and slightly bigger amygdala. We don't know which causes what. Is that because the depression, I mean, actually one of my aunt, it does a lot of research on this. One of the hypotheses is with depression, people under stress, so they have a higher cortisol levels. So that might shrink down the hippocampus. And the second part is maybe it's because people have larger amygdala, so they're more emotional sensitive to certain things, and then they might cause more likely to have depressions. So we don't, and in terms of the long-term effect, people with depression does have slightly higher chance, especially anxiety and depression together, of getting neurodegenerative disease like dementia and things like that. But again, people with dementia, 50% gonna have depression. So really is a come together in many of these things. Sorry, there's no simple clear
So,
may I ask a question here?
Huh?
That means depression could have a genetic factors?
Yes, I think it's pretty high. The thing is, depression is a genetic risk factor, but doesn't guarantee you're going to have a depression. So almost, let me see, what's a better example? Oh, almost like a parents. Tall parent tends to have tall kids, but doesn't mean that for sure you're going to have a taller kids. So when you both have parents has a depression, then your kids have much higher chance getting depression, but it's no guarantee they will have it. But even with short parents, sometimes they get taller kids. So even both their parents have no depression, it doesn't guarantee that your kids will not. And there's a multifactorial to this disease. So it's not just a single determinant by gene. There are multiple things like traumas, what they call personal experience, how you solve the problems. That's, I don't know, that's maybe come later. So the thing is, depression, so now simple and we don't understand it. The way I understand depression is really how we treat it, reflecting on what kind of system we can alter to restore the balance. And that also give me the sense about what causing depressions. So when we typically, yeah. Okay.
Oh, that leads really well into a question that Michelle actually has regarding antidepressants.
Okay. Yeah. So that's the thing about treatment. So we know for a long time, people don't know how to treat depression. And in the old days, people just don't treat it, let it go. Hundreds of years ago, people get depressed. But actually, one of the best treatment for depression is physical exercise. That might be part of why people in developed countries, we sit here doing Zoom. We're not running around like farming or chasing animals, hunting and gathering. So maybe that physical part of us is essential for us to keep our brain in balance. When we don't have that physical part of it, we're sitting here daydreaming all day, getting yourself depressed. So that's the number one treatment I would think has the least side effects. It's really getting physically active and physical exercise. And then that's a part of the reason I think why people get depression. The second part is really, but about 1980s, we start getting this SSRI, serotonin. Prozac is the very first one. And suddenly everybody getting better on this. So in depressed person, we do know there's serotonin level drop in the brain. But the SSRI, was that really causing the treatment effect or not? We don't know for sure, because when you take the medication, the serotonin goes up in the brain right away, but we don't get the benefit of this till 2 weeks later. So a lot of time we're thinking maybe it's not truly the serotonin in the brain. It is made because a lot of SSRI also help the neuron to regenerate. So that might be increasing more synapses. So that's another big part of it. You know, in dementia, exercise also helps. The dementia also lose neural synapses. So I think that might be depression, just a form of a different kind of dementia. So the brain doesn't work in the emotional part of the brain. It's failing, except this part of the brain is more regenerable. So when you exercise, taking medication, it can restore the balance. So that's second big thing, what causes depression, what treat it. There are so many different kind of antidepressant. In the old days, we have this SSRI, but also a tricyclic.
We've got a question from a yeah.
Hi, I have a question. This is from Lan Wu. So you talk about the positive effect of physical activities on maybe fighting depression, but the example you gave was that, you know, in the old days, people were hunting. So I think this is slightly different from the typical physical exercises that we engage in. So my question is that, does the physical exercise have to be goal-oriented? You know, for instance, I'm hunting for a deer, or I have to win in certain kinds of games, as opposed to just, you know, running on a treadmill. That's my question. Thank you.
Yeah.
Okay.
So that's a very good question. Unfortunately, when we do scientific study, at this stage, we don't do a goal-driven exercise. We do mostly 30 minutes cardiovascular, because that's a kind of a thing we can measure. We can measure people's heart rate. They have to go to certain heart rate, then go to certain like sweating a little bit. So that's our goal in exercise. In terms of what helps people, people do have study. Actually, it was a JAMA study, a different kind of exercise. What exercise is better for, not just for depression, but for like general health. Then they found out the most time the non-competitive team sports are the best. So if it's purely goal-driven, like the professional soccer player, they actually do not get the same benefit of exercise. Maybe they exercise too much. Than just your like after school, like basketball with a bunch of friends. That actually helped the most. So a non-competitive team sport is the best. And then the second best, I think, was maybe racket type of sports, so that you play it, not team, but at least interacting with others. I think the least beneficial, even though it's still beneficial, are the kind of we call loner sports, like the swimming, the runners. They just do it by themselves. They get the exercise they needed. They're still better than not exercising, but compared to the team sports, they just don't get the same amount of benefit in terms of health benefit.
Yeah.
So maybe you're right. Maybe the goal part it is there, but we just don't have.
Can I ask a follow-up question? Because you gave the example of the team-based activities. So is it due to the social interactions that you have with the team members, or is it due to the physical exercise itself?
Yeah, so based on this data, we can imply maybe the team interaction are the critical part. We just need to do more study on it. As a scientist, I cannot say yes or no without doing a study on this. Sorry.
Yeah.
Thank you.
To add on
Very
to that,
interesting.
actually, another theory regarding exercise and its, I guess, potential in, you know, at least alleviating some of the symptoms of depression is that in general, strenuous exercise causes your body to release endorphins, right? As you know, a part of, you know, the way your brain interacts with, you know, the body, right? They use neurotransmitters, right, which are a way of, you know, your brain telling, you know, your brain how to do things, right? And higher levels of endorphins are linked with, you know, elevated mood, right? And, you know, general satisfaction and fulfillment, right? Which actually regarding like neurotransmitters, that actually brings us back to I guess Michelle's question regarding like antidepressants.
Yeah, so what I was gonna ask, like, how exactly do antidepressants work?
I think that's the thing that we don't. I mean, a lot of time we hypothesize how it works, and then we try to test it out. So most of the antidepressants, there are about 4 big classes of antidepressant, right? The SSRIs, which really replace the serotonin in the brain, and there's SNRIs, which is they replace the norepinephrine and serotonin in the brain, and there's a MAO inhibitor, which is a mix. The MAO is enzyme that degrading almost all the neurotransmitters. So by blocking the degradation of all the neurotransmitters, that also helps. And the last one is the tricyclics. Again, it's not a very pure neurotransmitter in single type. It increases levels in multiple neurotransmitters. So all of those actually works in different degrees. In clinically, we use it differently. Older people, when they get depression, we try to use the one like SSRI, like the serotonin only, because we don't want to cause side effects. But for younger people, especially in my population, the one like 20, 30-year-old has severe depressions, we want it to be quick. So we give them the kind of not very selective neurotransmitter enhancer. So they have multiple neurotransmitters goes up at the same time, like norepinephrine, dopamine, acetylcholine, and serotonin. And they go up at the same time, then they get a dramatic response. But in older people, they get a side effect because they get cognitive side effect when they're too much like acetylcholine or something like. So how it works, that's our hypothesis. We think it's really by increasing the neurotransmitter, and then the brain will function better. But in real life, it doesn't always pan out to be like this, because as I said, most medication, when you take it, like you take a Tylenol, that it works in a few, like half hour, but neurotransmitter takes at least a week or 2 weeks to work. So people are thinking why it takes so long, because by taking that pill, the neurotransmitter level in the brain should go up within like a few hours or days. So that's the second part of it. We found a lot of this medication also increase the neural synapse formation, and also increase the cell, like its neural growth factors secretions. And also not only the neurotransmitter treat depression, but also, we used to have electric convulsion therapy, like the people who zap the brain, and then the people feel better. Actually, it's really effective, 90% effective. And also
it works really well.
Yeah, except you lose your memory a little bit. Part of the side effect.
Depends, actually. They've gotten significantly better at that, but yeah.
That's true. We don't do it here, but when I was a student, we do a lot of this almost every day. It's quite exciting to see. But now we use much more kind of an elegant way of stimulating the brain. We use transcranial magnetic stimulation. So basically, you take a strong magnet like this and put on the surface of the brain, and then you give a magnetic pulse, then causing a small, like a electric current in the surface of brain. And that actually works really well with minimal side effect and doesn't really affect the memory that much. So
does that really work? I
Yeah.
don't. I think the efficiency is probably less than 20%. From the person I know, 80% doesn't work, maybe even less. That was really a failure of the TMS.
The thing is, I think in double-blind trials, sometimes it's harder to see the effect. Maybe it's lower, but in real life, this is what part of my research doing this too. We see a pretty dramatic benefit from it, because I think we select the patient a little bit better. We only select the people who we think can help. And also by doing this, when you're not in double-blind control trial, you give them the benefit of psychotherapy. They might get some placebo effect because they think this is something they have to come in every day for like 4 weeks, and then they actually just feel better. So actually, that's another part of the antidepressant trials. So because depression is not just a neurochemical treatment, it's also a psychiatric treatment or
yeah. Why the mental illness, especially depression, do not categorize it like cancer? You have stage 1, 2, 3, 4, 5. Depression, why they don't categorize it? That's a major failure in the mental health.
Yeah.
Because if you are different level, the remedy will be totally different. The TMS basically for major depression is 0. Okay. For moderate severe is 0. TMS is just a joke. Really, frankly speaking.
Yeah.
So why not the mental health fail miserably? Do not discriminate the different level of depression. Just the generic label depression. That's really disservice for the whole society. It's really bad.
So just to like
and
quickly
also
clarify here.
another thing I like to point out, antidepressant also fail miserably. You know, at least 1/3 of the people who are non-depressant doesn't have any effect. So how you guys approach that? You know?
So okay, let's go back one more step. So when we do clinical trials, the placebo effect is about 30 to 40%. So when they say
it's a really joke. I don't know why they don't categorize depression. That was a total failure. I don't know. The European also do not discriminate. I do not understand this. So it's total failure to mental health. Total failure.
Well,
the antidepressant also fail 1/3 of the people who took it. I don't know why people still mention it. Oh, but people still have the COVID it. Okay, but it's fail miserably.
So in terms of treatment efficacies, so by medication alone, it's about 80 to 70% effective. So as I said, about 20-30% people don't respond. But they can also do psychotherapy, which is really talking to somebody, solving their problem, to kind of cognitive behavior therapy. So that alone, it also works about 70 to 80% of the time. But if you put these two together, then it works 80 to 90% of the time. So it's not a simple solution. And what's more important is whether the medication is going to work or not. It's not depending on what the medication you're taking. It's really depending on how the patient and the therapist's relationship. If the patient believes the therapy is going to help them, then more likely it's going to help. If
no,
the patient
first, why you guys do not diagnose in a different category? Because some just beyond therapy can really do anything about it. Some people are so sick, it's like stage 4 cancer. You basically have nothing you can do about it. So certain
we don't give up.
is like that
depression. So in stage 4 cancer, we will say, well, you have a 98% death rate in like a couple of years. In depression, we don't give up, not even a single chance. We don't. But
the approaches will be totally different at that point. Therapy is basically a wasting of time.
I think in real psychiatrists, we do differentiate in a mild, major, and a suicidal ideation. So there are different kind of treatments. They're like you said, like the medication, their inpatient treatment group, and the people who are severely depressed, like in catatonic stage, we do give them ECT right away because that would make a huge difference in their life.
But ECT had a huge side effects. How many people can stand for that? What percentage can stand for ECT?
I would say 100% people who did it. They because they at that stage, a lot of people don't have their own kind of volitional decision making anymore. They're in such a state that they're not even making any sound decision.
By the way, I have my last question. Then I won't speak anymore. How long have you practiced the medicine?
I graduated medical school in 2003, so it's about 19 years. So far.
19 years. Yeah. Oh, that's quite a long time. So
I know. Sorry.
You know, it's kind of depressing that people handle the mental illness. It's really sad.
Definitely. Of course, that's why they call depression. They're sad.
Can you answer me why they do not categorize it? Like try as much as you can to quantify different category. Why they do not do that? Like as I said, like cancer stage 1, 2, 3, 4, 5. They will require totally different approaches. Why just genetic depression and most say severe, maybe moderate? Why the more quantify it? Why the industry cannot do anything about it? The mental health war. I once want to talk to a psychiatrist and I said I would like to participate in that to change that. If they do not change that, that is really sad for the whole industry.
I think you're great. So, you need to talk to the the main point is you need to talk to some politicians who really kind of deciding the funding revenues to where to go. depressive disorder get one of the least research fundings. Cancer and cardiac disease get one of the highest resources in research. So definitely, I think your ideas is really important. If you talk to the politicians who really kind of allocate the resources, that will make a huge difference for us. I mean, as a clinicians, we kind of only can use available knowledge we have. Without the research, we just don't have that, unfortunately.
Yeah. But why you guys propose that? Why there's no activists to pursue those things?
Yeah, we do propose, but we have to test it out. We can imagine there's stage 1, 2, 3, 4, but then we need more resources to really testing the things out, whether this really works or not, whether it's going to predict people's survival rate or not. That's something we don't have.
No, it's not survival.
Hey, Lola, I'm sorry. Thank you so much for asking questions.
I'm leaving. Goodbye.
I want you to give other people an opportunity also to ask a question, okay? Because you've been asking the same question 3, 4, 5 times.
Very important question, though.
Appreciate
it is an important question. I want to add on to that really quickly and just say that I do want to clarify that, again, we categorize depression primarily based on different forms because it does manifest in different forms. You have forms of depression such as like bipolar, right? Bipolar happens in 2 different forms, A and B, right? You have seasonal affective disorder, you have like postpartum depression, and there are a lot of different categories of depression, right? And I do apologize for being, I guess, a bit over general about this, right? In general, when we talk about depression here, what we are discussing is clinical depression or major depressive disorder, which tends to have a pretty, like, I guess, specific set of symptoms, right? And I do agree that, you know, there are varying degrees of severity, right? It's just that, like, I think it's difficult to, I think, measure a lot of this kind of stuff without like further research. So I just want to say that we are about 10 minutes away from the end of the session. At the end, Rich will be giving, you know, closing prayers and closing remarks. So I did want to open up the floor for any questions from our audience or any questions from our other, you know, I guess, a discussion panelists, if they have anything they want to add.
So, yeah, I just have a quick question. I'm wondering for the teenagers, what's the major therapy? Because Dr. Chow, you talk about for like younger adults at 20 to 30 years old, but I guess most of the audience here are probably teenagers. And if you can talk about teenager depression, that'd be great.
So yeah, so for teenager, number one, teenagers depression, sometimes they might even present differently. Like we always say that when we understand depression, we think of people feeling sad, they're just crying all day, they have no hope. But in teenagers, sometimes they express themselves differently. They might become more irritable. They might become more kind of acting out, become behavior issues. So those might be their sign of depression. They're not just always sitting there and crying, not doing anything. Sometimes they can be more kind of active in the way, creating more troubles. So that's number one thing. Number two, in terms of treatment, so in teenager, because the brain is really growing, developing. So I think most of the therapists, I'm not a pediatric psychiatrist, so I would hesitate to give a general idea what's going on. But most, I think the therapists are kind of more conservative in the way that we don't want to start with heavy medications. We want to make sure this is a truly depressive disorder and make sure the patients are safe, because those are the ones that all mood medication has certain side effects. And they, especially when the teenager mind are growing and learning knowledge, by altering their the brain function is a high risk thing. So I think medication is a big part of it, but I think psychotherapy, which can be given by a psychologist, but also family support, or friends and family support, understanding what's going on, and also doing kind of encouragement. We call cognitive behavior therapy, which basically really just training a person how to react to certain situations. So those are important in the way that if a family can help out in that way. So I think being a family, number one, getting them the health care they need, finding the good psychiatrist or thing. Number two, being really supportive instead of being judgmental. That's actually might help more. And then the last part is really exercise. Even though a lot of depressed kids, they don't want to do anything, taking them out or dragging out.
That's why they should do something. That's why they should do something.
They should go hunting.
Okay, we've got two questions, one from Caitlin Chow and one from Shan Zhao. So Caitlin, you have the floor.
Yeah, so earlier you're talking about kind of like what you should do, like as a parent if your child is depressed, but like as a friend, if you notice your friend showing like some symptoms of depression, but you're not really sure, like how should you bring it up or like how can you help them out?
So being a friend. So I was thinking that, of course, you guys are teenagers. You probably can talk to each other much better than me. I'm so far away from being a teenager. But in general, we think being supportive, really just caring more about your friend, just being with your friend, that helps a lot. Instead of isolating them, just say, oh, he's just acting out. Sometimes they do need a long time, but I think just being next to him without even asking questions, just sitting next to him, that actually might be a form of support. Some people, that's more than just walking away. And sometimes can gently just ask how you're doing, open-minded. So you need any help or do you how you're doing? Those kind of not being kind of being judgmental kind of a question, just really being open-minded questions. So are you doing okay? Or like I have something to share your own interests, bring them out of that thing, because by distracting them from that, sometimes does help. Of course, you should read into their mood. If they already get annoyed, and keep on pushing.
I think adding on to that, right? I think with a lot of situations like this, right? I think as a friend, right, often the first instinct is to, provide a solution or provide suggestions to your friend, right? And in fact, it can often be sort of like counterproductive to immediately, go like, oh, here's some ways that you can fix your problem, right? Especially with mood disorders, right? Because a lot of times with people who are, really struggling with, anxiety or depression, right? They're mainly looking for someone to talk to and someone who will listen, right? And so if you give them a chance to talk about it, even if, you don't feel like you're, making any change, right? Being able to, like sort it all out by, talking to someone else about it, right? Is like probably the best way of offering help. And Shanzhao, you have the floor now with your question.
Yes, thank you. I do know some nonprofit organization is focusing on your mental health, and they do have fundings to decide what to do to help teenagers or yours. So what suggestion would you give to a nonprofit organization like that? What can they do?
So in terms of resources, that actually I'm not very familiar with that. I think maybe Annie can look it up and maybe post to the group. There are a lot of nonprofit organizations, I think, providing resources or buddy systems. So that part, I'm sorry, I'm not, because I have limited resources to the outside world. I know in the VA what I do, but not in the regular world. Actually, there's one thing I want to mention about Juju's comments. So Juju, when Juju said that, Annie saying that don't give advices. So even though I'm not a licensed psychotherapist, but I do take some classes. So number one rule in that is really don't give suggestions. Don't put your own personal input in there. Let them talk about it. So that a lot of people will find a way out. They actually, just by expressing themselves, number one is release for them. Number two, by thinking about their own problems, they will eventually figure a way out. So that's the best part. Like just sit there and listen and just agreeing with that, or just listen, take it in. Try not to impose your own thinking over it.
To, I guess, add on to that is if you're looking for, I guess, organizations that provide, mental health resources, the SAMHSA, or Substance Abuse and Mental Health Services Association, is a good one. NAMI is a good one. If you look online, there are plenty of, like I guess, resources available, right? And so I think.
No, sorry, that's not what I meant. Because I do know some organization receive the funding. They are looking for directions what to do with your mental health.
So what to do with your money?
Yeah, exactly. So what would you suggest? What do you think that, what's the direction you can recommend?
I think basics in education is a big part of it, especially in Asian populations. Asians always think mental disease, they shy away from it. When I was a fellow at UCSF, we have two research projects. One is about mental health, one is about pregnancy. So both free kind of clinic. So Asians only go to the pregnancy part, and then in Hispanic, sorry being racist, Hispanic use mental health much more than the pregnancy care. So in Asian population, I think just educating about what is there, what needs to be addressed, I think that might be a big part of this.
Yeah. We have another question from Lauren.
Hey, hi, I'm Lauren. Hi, I'm an old friend of Dr. Chow. So I listened to the whole conversation. Thank you so much for the information. As another physician, I think it's kind of important to always understand disease is not a single factor thing, as you already mentioned over and over again, especially in teenager time. So sometimes the diagnosis is not just go look for Dr. Chow or a particular psychiatrist. It's actually a combination of the family, the friends, the psychiatrist, the psychologist, the pharmacist, the neurologist, all of these, it's really playing a role of how everything play out. And for the same reason, treatment is never simple. It's not one drug that's going to fix everything. And I think Dr. Chow's suggestion, I just want to concur with that. It's such a great idea just to say you as a person, be the friends, be the family, be supportive, be there. And that itself, on top of what you guys were just talking about, the very last part, it's the fundamental education to know it is a thing. We don't understand it completely. We can't categorize very well, but it is a thing. We need to educate ourselves. And therefore, when your friends have a sign, you at least are aware and willing to be there. And that's willing to be there may already help to this one particular individual get through that without ever getting into a real diagnosis. And that's probably, I think, is most relevant listening to your guys' conversation. That's just a comment.
Thank you. By the way, Dr. Peng is a pediatrician, radiology pediatrician. So she probably knows more, even though she looks at the brain all the time.
All right, so we're about wrapped up here. I don't think we have any more questions from the audience. So I will hand the floor over to Rich here to finish up our seminar. Thank you all for being with us.
So Annie, actually one last question for me. I have a minute? So if the patient feels better, can they just stop medicine, or that's something you have to be on the medicine all the time?
Yeah, so in the adult world, if people had one episode of depression, we treat them for 6 months. If they feel better, they could potentially stop the medication. But then you need to be close monitored. If they have a second relapse, like they have a second depression, then our typical thinking is then they probably need the medication for life, or at least for many, many decades. It's high risk to stop it. So we give them one chance. But again, this is just a general rule. Everybody is individualized. So you really have to figure out why. Some people have depression maybe triggered by certain things, and then when the external trigger removed, maybe they're not in the situation anymore or the problem is solved, then you say, well, let's give another try. If the depression really just coming out without a clear trigger, we think maybe there's underlying issues, or especially with a strong family history, then more likely we'll keep them on medication, especially the suicidal risk is high. So maybe there's another point I should talk about it. So for suicide, there's a two important part of it. One is the motivation of it, like how much they want to kill themselves. The second part is the lethality of it, like how effectively they can kill themselves. So the people who are super effective killing themselves, then we'll be really worried about. Like most of my patients they're warriors, so they're soldiers. They know exactly how to kill people. So that's why they're so good at killing themselves. But then another part of my patient is a dementia patient. Even though they want to kill themselves, a lot of times they cannot do it because they couldn't figure out how to do it. So for them, I'm not that worried. But for the young soldiers, even though just a slight thought for like a few seconds, a few minutes, they could really accomplish their goal. So for teenagers, similar thing. Some teenagers are much better than others in achieving their goals. Some people, they're kind of just, in a way, it might be even better. They just never really get anything done. So it's unlikely or less likely they're going to succeed in what they're doing. The people who are very good at what they're doing, they get things done right away or impulsive in the way, then those are higher risk.